طبعا في البداية طبعا أحب أشكر الدكتور ندى على الدعوة الكريمة. Very elegant conference, always in success. شكرا دكتور ندى. Thanks to the chairperson. Dr. ندى asked me to talk about simple case of FNA or FNB. So I found this simple case really help you to trust your eyes and your needle. I have a case was transferred for me for one of my eminent colleague for cystogastrostomy of a diagnosed patient of pseudo-pancreatic cyst. This patient was 27 years old, complaining of abdominal pain, vomiting, no fever, with significant weight loss. So we have a symptomatic pseudo-pancreatic cyst patient. اللابس بتاعها كانت within normal except slightly elevated amylase and lipase. Abdominal and pelvic ultrasound was shown this patient has bulky edematous pancreas with pseudo-pancreatic cyst with evidence of acute pancreatitis. So we have a symptomatic patient with proof that he have acute pancreatitis. But there is problem here in the CT, that is the cyst was related distally to the pancreatic tail, associated with thickening wall of this cyst. So there is some debate here that we have cyst post evidence pancreatitis, but there is abnormal location, abnormal feature of pseudopancreatic cyst. This patient the pain is worsening after seeking medical advice, and conservatively there is no improvement at all. So there is some colleague advice here for aspiration, and it also confirmed that elevated pancreatic cyst, amylase and lipase. So there is no doubt that you have ideal case of post-pancreatitis pseudo-pancreatic cyst, proved clinically, radiologically, and aspiration by serum amylase and lipase. So this patient is underwent EUS guided cystogastrostomy. But when I going to do those procedure, I start investigated well and clinically morphological feature of this cyst. And this was the EUS image of the cyst. Multiple complex cystic lesion with septation, with some debris inside, with transmural nodule. So I start to hesitate, and I don't rush to start the procedure. Dr. Amr Al-Fouli, do it or not?
You mean for draining?
Drainage.
No. This septation is not typical for drainage of pseudo-pancreatic cyst. The wall is thickened. There is internal ecogenic structures. It's not, for my opinion, it's not clear.
Completely right. Completely right. So I start to insert my needle, and this is what I found. So I start to hesitate again. This is the classic use of pseudopancreatic cyst. Decision هيختلف تاني. Completely restrict to Dr. Amr Al-Fouli concept. This is not the feature of pseudopancreatic cyst, and start to complete aspiration of this cyst fluid, and this is the feature after aspiration of more than 400 milli of this cyst. Start to clarify the cysted have marked thick wall, purely septation, transmural nodule. This is not an ideal pseudopancreatic cyst. So start to insert the needle in microcystic area in this cyst, and this is, I found, this is thick, whitish material, positive string sign. This is ideal of IBMN. And aspiration CEA and CA 19-9, once elevated, there is purely mucinous cystic neoplasm. And for my culture, this is the simple procedure I always do after any pancreatic cyst fluid aspiration. Glucose level in the cyst is low, and there is no doubt that it is not an pseudopancreatic cyst, and this is ideal of mucinous cystic neoplasm. For Dr. Abul-Magd, differentiation between different types of pancreatic cyst is required. Careful review of clinical history, cross-sectional imaging may be helpful, but always trust your needle and cystic fluid crystallization. Thank you for kind attention.